Hello, everybody, and thank you for joining us today. I'm Dr. Matthew Weissman. I'm a primary care doctor, and I'm the site chair for medicine down here at Mount Sinai Beth Israel and Mount Sinai downtown in Lower Manhattan. Thrilled to have all of you join us today, and really excited to be with our guest, Dr. Sreekala Raghavan, who's a primary care doctor and our program director for our medicine training programs. Dr. Raghavan, thanks for joining us.
Thank you for having me.
So I want to talk about all kinds of things that are new and exciting in graduate medical education, but I thought maybe to begin with, we could talk a little bit about what graduate medical education is, and even like what does it take after high school to become a doctor?
That's a great question. I think a lot of folks get nervous about how long the training is and what all the different steps are, but basically, folks don't even really need to know necessarily in high school that they want to be doctors. And if they realize that in college that they want to become a doctor, they essentially would just have to take science courses that would allow them to complete a pre-medical course. It's not a major, it's just a series of courses that you would need so that you can take your MCAT, which is the national exam that helps you get into medical school. And then you apply for medical school. Medical school is 4 years. And at the end of medical school, you have a lot of textbook knowledge, and you've had a couple of years of being in clinical rotations where you are seeing what's going on in all the different areas of medicine and surgery. And then at the end of medical school, you have a chance to choose what field you want to go into, and you match into a residency program. And residency programs can vary in training years from like 3 years to 7 years, depending on what you're choosing. So for example, internal medicine, where I'm at, is 3 years of training, but neurosurgery is 7 years. And beyond that, you can apply for fellowship, which is if you want to subspecialize in your area. In internal medicine, we have a whole host of subspecialties, including ones that most folks have probably heard of, like cardiology, pulmonary medicine, allergy, endocrinology. There are a whole host of them. And we are here in graduate medical education to support folks after medical school.
So that's great. So we'll leave neurosurgery and those ones aside for a minute. But, so people come out of medical school, they match in residency here, and they want to do internal medicine. What are sort of your overall goals when you're training people who are going to become internists? What is it that you want them to know?
For internal medicine, what we're really focused on is the whole patient. A lot of patients will either come into a primary care office or into the hospital where we take care of them as internists, and they will have different conditions that may be managed by different folks. But our job is to have an overview of what's actually going on with the patient, and if the different goals from different services make sense altogether for that patient. We take ownership over that patient and responsibility for their entire experience, and helping them move forward with understanding their own health and feeling good about where their medical care is going.
Right. I sometimes tell my patients that I'm like the quarterback for their care, that I'm not necessarily doing everything, but I'm trying to make all the pieces fit together so that they're getting care that's all, sort of symbiotic. Is that sort of the right attitude?
Yeah, I think one of the things we really try to teach in residency is understanding that if somebody else is giving a recommendation, that you don't necessarily just need to take it and run with it, that it's really your role to evaluate all of the different pieces, the moving pieces for the patients that are under your care, and try and see what's the best one unified plan moving forward for that person.
Right. That sounds great. And, we're not only training general internists to go into primary care and hospital medicine, but we're also training people, as you mentioned, who are going, on to fellowships, to medicine subspecialties. Is there something, how do you think about what sort of general skills they need before they go on to fellowship?
That's an interesting question that residents will often ask about why do they need to have 3 years of internal medicine training if they know that they want to be a cardiologist? And really having that basis in internal medicine allows them to think beyond the more narrow scope that they're going to be training in the future. And it allows them to work more completely in, within the medical system and understand where the patient's coming from. We really try to create that sense of understanding the patient's perspective and their experience, and how we're privileged to really be able to take care of folks.
Yeah, that's really interesting. So, it strikes me so much of graduate medical education hasn't changed in a long time. I think our Beth Israel program dates back to the 1940s. But there must be a bunch of stuff that's changing. I mean, even sort of separate from the pandemic, what are sort of the moving pieces, or what's like the cutting edge graduate medical education stuff that I, as a chair, as a primary care doctor, or as a person who has a doctor, like, what do I need to know about?
That's also a great question. We really think of it in two different realms. So one is, what are the modalities that we're using to teach folks to really practice medicine? And that's changed a lot over the last few decades, but certainly even in the last year with the pandemic. We use a lot more flipped classroom models. We use simulation a lot more. And then really moving into the virtual education realm over the past year and a half has taught us a lot about student engagement or resident engagement, and how to really have people feel like they understand the hands-on experience that they're going to be having after experiencing some teaching sessions about what they're going to see in person.
So can you just tell me a little bit about what those mean? What's a flipped classroom, and how do we do simulation?
Yeah, so simulation at Mount Sinai Beth Israel, we actually have a simulation center, and it's an incredible place for our residents to really be able to, and our fellows, to really be able to practice hands-on skills with mannequins, essentially. But these are not regular mannequins. They're dummies that have all sorts of physiologic functions that can be simulated from behind a mirrored glass. So folks are watching what's going on, and somebody behind the glass, the Wizard of Oz, is essentially changing the situation on the trainees so that they can handle new things that are going on.
So they're like dialing up the heart rate and dialing down the blood pressure and whatever in real time?
Yes. So, and they know what's going on, what kinds of interventions the residents are trying out on, in that situation, and they'll have the dummies' vital signs and really their physiology kind of match what they would expect if this were really happening to a real person.
Cool. So, I mean, I think even before the pandemic, we had started really rolling out things like telehealth, where we were doing video visits with patients, and we had residents doing a bunch of that. We do a lot of e-consults here where we send, asynchronous messages to subspecialists to get feedback on specific patients in the chart. I know you talk a lot about point of care ultrasound, which is stuff that we've been rolling out throughout the hospital here. I mean, are those kinds of things like the future of medicine, and what, how do we teach residents stuff that we didn't learn in residency?
I agree. I think there are so many things that are just new all the time in education, and obviously in medicine, which is very, very dynamic. And with telemedicine, that had been coming for a number of years. And then last year, it just got turbocharged with the pandemic, where we just had to learn how to really deliver care in the best way possible. We were able to really take just kind of moving from the logistics of how to perform a telemedicine visit, how to provide telehealth care, into what are the best ways that we can communicate with our patients via a digital platform. What are the best ways we can communicate with our teachers, our preceptors, during a pandemic where we can't be all together in the same place? And what are the best ways for us to communicate with other physicians who are taking care of our patients? And streamlining all of this to provide something that feels very comfortable for the patient, and also helps us to be really efficient on the practice side. That was a real work in progress last year, and I feel like it really helped us all feel like we were on our toes as educators and as practitioners.
Right. It does really feel like we're communicating with patients in so many different ways. You know, I'm getting messages through our electronic medical record portal. I'm getting phone calls in a couple of different places. I'm getting emails and texts and, you know, all kinds of different things. Do we train residents in how to sort of balance all of that?
Yeah, I will say probably even about 10 years ago, we were not training folks to really handle all of these different things. And it's possible that residents really didn't graduate with a real sense of what it would be like to practice in the area that they were choosing. And truthfully, as educators, as we incorporate these different models into our own practice, we have to look at the data. So staying current in medicine really involves doing research. And in medical education, we do medical education research to understand at different levels how the things that we're changing, the things that we're teaching are really being used in practice. So we start with how are our learners really kind of feeling comfortable with the material that we're teaching them? And then are they able to hold on to that material that we're teaching them? And you know, it goes all the way up the line to, does it really change their practice? Down the line, are they doing this in real scenarios that they have with patients? And ultimately, what we're hoping is that these different modalities that we're using and the new content that we're teaching, that it affects, you know, patient safety in a positive way, that it affects patient outcomes in a positive way, that we're really able to keep folks out of the hospital and we're able to keep them healthy and happy in both their physical health and their mental health.
Right. I think that's a thing that you and I both talk about a lot as primary care doctors about, you know, sort of the whole shift in healthcare from this, you know, inpatient setting where all the action happens to really moving more and more into the outpatient setting. And certainly here at Mount Sinai Beth Israel in downtown, a lot of our work is shifted into our, as you've seen, our beautiful space over in Union Square that's, you know, this amazing multi-specialty space, and the inpatient footprint has shrunk over time. And so, you know, I'm sort of curious how that affects your own practice, but, you know, but also how you prepare the residents of tomorrow who are really going to be living in a world that is way less focused on inpatient medicine and inpatient consults and more focused on that sort of collaboration in the ambulatory world.
I think, you know, everywhere we're trying to move a little bit more towards having ambulatory training, but here at Beth Israel, we're really taking that to the next level. We're trying to create ambulatory experiences in really every subspecialty that our residents have a chance to be a part of. And taking a step back and thinking, you know, when we train internal medicine residents, we historically have always spent a ton of time training inside the hospital and taking care of patients inside the hospital, whether that's in the general medicine service or on the hematology oncology service or the cardiology service. But the truth is, when those folks come out and they're trained and they're practicing in those fields, they're actually practicing mostly in the ambulatory realm. So we're creating ambulatory experiences for our residents in all of these different realms so that they can see what the day-to-day is like and how much they're really going to have to handle, including the behind the scenes things that we talked about earlier, like you're getting, you know, phone calls and emails and all sorts of different
consults.
And e-consults. And so they're able to actually see how folks practicing in all these different fields are able to manage their full day, their full week, a full month. So that is, you know, I think the future of medicine for our trainees, but certainly for our patients. I think they appreciate that they're able to see that trainees are really competent when they come out in being able to communicate within all these different modalities.
And I mean, when you think about sort of the regulations or what's required by the ACGME and these other accrediting bodies, has that moved with the time to sort of enable all this?
Yeah, so that's a great question. This year we actually just came, not we, but the ACGME, which is the Accreditation Council for Graduate Medical Education, and they accredit programs, whereas the different medical boards, like the American Board of Internal Medicine, certifies individuals as physicians to be able to practice. So the folks, the ACGME that accredits programs, they came out this year with a new version of their milestones, which they called Milestones 2.0. So just like in children, where we're hoping that that kids are gonna meet different milestones at different ages in their development, we have milestones for trainees in not just internal medicine, but in all of the different subspecialties and beyond in their subspecialty training and fellowships. So the Milestones 2.0, which started this July for certain specialties and is going to be rolled out over the next couple of years, includes a lot of newer skills that we're seeing that our residents need to be trained in. So for primary care, that might look like a little bit more population health. So how do we manage a panel when our patients are not physically in the office all the time? How do we reach out to these folks to make sure that they're staying healthy in the community? And beyond that, we have specific milestones now in digital health, in providing telehealth services and communicating in the telehealth realm, and looking at patient satisfaction through different modalities of receiving their care, whether it be by a video visit, a telephone visit, an email communication, or a traditional in-office visit.
So population health is really interesting, right? Because it's, I guess, the historical model is like, sure, you need something from me, I'll be in my office from 9 to 5, Monday through Friday, come meet me there. And that's not really what ambulatory care is like anymore. I mean, not only am I in my office way different hours and weekends and all kinds of other times, but we got to take care of the patients who aren't coming in.
Yes.
I mean, what does that look like? And how do you get residents to understand that?
Yeah, so we do actually train beyond having sessions in pneumonia and urinary tract infections and really like the basics of medicine. We actually do have curricular elements that cover talking about how do we think about ourselves as managers of a panel of patients? How do we make sure that all of those patients who are in the community, staying in the community and not necessarily in the office with you, that they're staying healthy and they're on top of their preventive care? So a lot of this relies on using a really interdisciplinary team model of care in the outpatient setting. And we do work a lot with residents to feel like they're part of that team with chronic care nurses, social workers, dietitians, certified diabetes educators, all of these folks.
Right, our pharmacists.
Our pharmacists, absolutely. That all of these folks come together to think about all the little moving parts about somebody's care. And how do we make sure that if folks are due for something, like they really need to come in for a vaccination, for example, or they need to come in to have colon cancer screening or breast cancer screening done, that we're reaching out to them and letting folks know, because they may not realize that they're due for that type of preventive service, and they may not have had the chance to come in and see their primary care doctor in the recent past.
Yeah, great. So, I mean, one of the things that strikes me about, what you said about getting, all these different ways of getting messages and these different ways of communicating with patients, and it happening at different hours, and even the people who aren't there, you have to take care of. I mean, it feels like that's going to lead to more sort of burnout and workforce problems. What can we do as leaders, and what can our residency programs do to try to combat that? I mean, certainly we're seeing it, in lots of places in the middle of a pandemic.
I think that's a very timely question. We certainly have seen a lot more need for support and understanding where our residents or trainees are coming from during the pandemic, and understanding the amount of themselves that they're really putting into their work. Even like 15 years ago, we weren't doing a great job of looking at rates of burnout and how we could support wellness and physician training. And that's really changed. Truly over the last 8 to 10 years, there has been a lot of research about burnout. And that just started with measuring burnout in our trainees. And beyond that, understanding that that's a problem. What are the things that really contribute to burnout? Breaking that down into, do folks feel like they have control over their lives, over their schedules, over the care that they're providing? And then turning that around and thinking about, how do we support our trainees on a personal, psychological, emotional level to be able to come every day and really give themselves into this work that is an incredible privilege, but also takes an incredible amount from you as a person. And a lot of the ways that we've really been able to support that is through team-based care. So providing a lot of services so that folks feel like the physician is part of this team of folks that's providing care for patients, rather than this sole person sitting alone in an office and they're the only ones who are making sure that patients aren't falling through the cracks. So the team-based care is a huge part of it. But beyond that, really providing services to residents, having it be available to them that they are able to really effectively transfer care if they don't feel like they can provide the best care that day or that week. Teaching residents how to really turn patients over to somebody who may be able to provide them with better care so that they can attend to their own physical and mental health needs. We also provide, at Mount Sinai Beth Israel, we have actually a lot of services beyond just having wellness days in our resident schedules so that they can schedule their own appointments to make it to their own doctors and to get their own care. We have a gym on site for our residents that they can use it 24/7, which is an incredible resource for folks who may not really have the time or the ability to get out to a neighborhood place and put in some time to attend to their own physical needs.
So thank you for this. This has been super interesting, and I know you have to get back to interviewing candidates for next year's class. So maybe before we go, I could just ask you a little bit. I'm sure there are some people watching us who are thinking about applying. They're in the middle of medical school and they're thinking about applying for a residency slot here. Can you talk a little bit about, maybe we should talk a little bit about the match process, but then something about, what it is that we look for when we're interviewing candidates, what makes a good fit for the Mount Sinai Beth Israel program?
For internal medicine, we are really looking for folks who are energized about really taking responsibility about the care or over the care of their patients. Folks who like working in a team and who are able to really think about what the perspective of the other members of the team that they're on might be, so that they can all work together at the top of their own ability and to really, to their own strengths, their personal strengths, to make sure that patients are getting the care that they need. Beyond that, we do look for folks who are really excited about being here and who feel like they would really be a part, an integral part of this community here at Beth Israel, which happens to be a really close-knit, wonderful faculty and trainees where folks really know each other. And I think, getting that feel for the place and that they'll fit, that's a huge part of it. But we're also looking always for people who are looking forward. They are interested in doing research and furthering their field, understanding the answers to questions that we don't know yet in medicine, which there are always so many things to think about and so many things to research that we're really excited to be able to support our trainees in doing that type of work.
Great. Dr. Raghavan, thank you so much for joining us today. Clearly, so many moving pieces in graduate medical education, so many things the same since 1948 when this program started, but so many, many things changing and continuing to change, and happy to have you here with us at the helm, making all these things happen. Thank you for joining us today, and thank you everybody for watching, and we'll see you next time.